So for the next one, what I'm going to do is show you a sideline traction manipulation. And the key is your top hand is going to be your block. Your body hand is going to be more of your traction force, and we're going to do a body drop to kind of direct our force a little bit more. So with this one, we can wind up still the bottom to make sure we're kind of at that target area. And then what I do is I have the patient just relax just like this. I don't do anything with them. Come up top just to get to me. And so this bottom arm is going to come in and lock in from the top, right where that segment is area. The bottom arm is going to traction out this way. So if I get here, traction, get right here, and ask, how's that feel? Good. So no pain. So again, this doesn't move here, and then drop down into it just like that. With that one, make sure, and actually this is what I messed up, make sure your stomach is not into their pelvis area, or you're going to come down into that. That's not going to feel pretty good. So I actually probably need to bring her into a little bit of flexion to make sure I'm here and not driving down into that pelvis a little bit. If it's hard to get, you can always throw a pillow underneath just to lift up a little bit, and that should help it out. Bonus thing that was not necessarily not onto our sheet, but I did want to throw into it, that's something I use quite frequently. This is an SI gapping, not manipulation, but an SI gapping technique, or a severely toned technique, just to help calm down this area a little bit. If I do have an SI, which is a true SI, which is pretty weird, and they're excessive force closure, I'll actually use this one. Or if I just want to calm down glutes that are very irritable, I'll use it as well. So what I do is you can actually leave the bottom one, just going to straighten out just a little bit. I just kind of want it out of my way. And what I'm going to do is I'm going to pin the leg right against my body, right? So that way I've got control. I can do whatever I kind of want. I'm going to come, arms just like this, to that posterior SI joint line. I'm going to come, I'm just going to lift up, and I'm going to go into leg adduction as I lift up. And all I'm looking for is a good relief. How does that feel? Good, good. Usually it should not be painful at all. If it is, I would say actually recheck the technique. If it's still painful, get off of it, because you could be, we know that the SI doesn't move, but if they're hanging on ligaments and we haven't really ruled that out, we could be technically taking them into more pain, and we want to get away from that. So this is a just good, nice, relaxing technique that should help our patients. Go ahead and sit on up for me at the end of this. Actually, just sit here and then face that way for me. Sit off to the edge right here. And then, do you mind straddling this for me? Other way. And then scoot back. Perfect. Scoot a little bit more back. Sorry for the sidewinder there. Good. Alright, so what I want you to do is kind of hug yourself as tight as you can, left above right. Good, good. So, a couple ways you can do this one. This is a seated TL junction manip. And I apologize, this bed is actually very hard to do this on. Now, how she has her hands, I don't have good control of her, so I don't like that. Now, if this is a smaller person, then it usually doesn't bother me. But, for anybody that's not like 4'9" and 100 pounds, I'll actually change up the arms a little bit. So if you make it easy on yourself. Go ahead. What I want you to do is go ahead and hold just like this for me. There we go. So again, I would do this honestly on most patients. But what I'm going to do is I'm going to come in. So now that I've got a little bit more control, and then sit up kind of straight for me. Good, good. What I want to do is there's so many different ways to do this technique. I want to side bend down till I feel it. And then once I get it come in my hand, I want to keep that side bend and wait till I lock out right there. How's that feel? So again, we're going to go down, side bend till I feel about right there, and then manip right into that, just like that. Alright, directional preferences can be hard to treat because how do we progress? I'm not a McKinsey therapist by any means. I like to, I was given advice by one of my mentors to think of directional preference, throw the idea of a disc completely out of the way, just throw it gone, and repeated motion just is what you make it. It's what makes this feel better. Clean that up and then work into the dysfunction. So, if we have a patient who often finds flexion as good, as it feels good, we want to work into that and then slowly work into extension. The first way we can do this is supine and everything like that, working knees to chest, etc. I want to progress as quickly as I can from an unloaded position to a loaded. Oftentimes I find quadruped is the next thing. So oftentimes what I'll do is start off in the prayer stretch or child pose, or if you're Australian, the lion pose. And what I first do is ask the patient, just keeping your arms straight, go ahead and just drop your heels back to your bottom. And what I want to look to and just kind of go as far as comfortable. And I just want to see how it goes. As you saw there, is like quick movements here. Does this move and this move, etc. Same from our assessment, we know what area we want to treat. A couple of things we can do. First and foremost, I can come in there straight with the wedge in this position, especially at that TL junction position. TL junction area, I can go in and work it just like this, going into that plane of the joint. Again, I'm going to use my thumb to feel that movement and make sure I'm getting it. Another thing I do is go ahead and come on up for me. Is I can go in here with my wedge, apply that superior glide I want, and go ahead and drop on down for me. Perfect. And then come on back up. Just like that. And that is a directional preference progression. The good news is everything I did here can then be taken into that prone with the legs hanging off position that we've talked about in lab. It also can be done in sitting as well. With the patient sitting off the edge, applying that glide, and then coming down. You can use the mulligan belt to put at the stomach to help with that as well. All right, go ahead and stand on it for me. And go ahead and face that way for me. So for our directional preference and extension, I'm always, of course, going to start this off in standing to see how they do, because hopefully this is what I found. And what I want to do is give them a little bit of control. So what I will do is kind of get them close to the bed. So go ahead and take a step towards the bed for me. So they've got this bed blocking them. Put your hands on your hips for me. And I just want you to bend back until you feel a little bit of that discomfort. Right there, come back in. Alright, go ahead and go again for me. And then come back in. Good, good. So I'm here, especially if our patients are pretty irritable, if they have like a catch, etc., just make sure it goes good. Other progressions is, in a directional preference, we want to start off in a static, dynamic, and then a therapist assisted. And then you can take that in addition to go weighted and unweighted. So I always can go, prone on elbows to prone supine to helping and assist here. If I'm going to do more of the hands-on, I'm probably not going to do this really standing. I'll probably do it more unweighted, but a way I can do it standing is come into here, kind of assist, all right, and then what I want you to do is come on back for me, do that glide, and then come back up, almost like a mobilization with movement.
Sounds well to that.
All right, finally, say your patient has a lateral shift. What we're going to do is try to get them out of that shift. I want the patient to be self-efficient as much as possible, enhance that self-efficacy. So say our patient is kind of just like this, shifted over this way. We'll test both ways to see if it does good. But I'm going to put them in front of a mirror, and then so say the upper half is shifted this way. I'm going to put their hand up here, and then their bottom hand here. And then what I'm going to say is, let's try to make the two ends meet. So go ahead and press there, and then relax. Press in and relax. Just trying to get that. If that is not working or it's too painful, I'm going to take them to an unweighted position and try to do prone press-ups from that kind of shifted position. Or, again, go into that static, dynamic and therapist, doing it in that progression as well. Another thing you can do is say that, they're kind of shifting into that extension. You can get them into a flexion bias and kind of directing it. So taking into between a chair, pushing up from that chair, shifting over. Or you can also take a towel, put it over the doorway, traction down, and have them settle in just like that. And that's a couple ways that you can address lateral shifts.